So as we are in this hypertension session actually, as the first speaker enlightened about the resistant hypertension, how do we approach, and the secondary cause of hypertension being quite prevalent to the extent of around 5 to 10% of the general population actually when you're going to pick up an hypertension. So always hypertension, especially the secondary causes, should not be neglected. The reason being most of the times you have an identifiable cause there and you can definitely treat it actually. So I have been assigned a job like how did I diagnose an adrenal pathology in my hypertensive patient actually. So I'll just dive into the case scenarios first. I have got two cases to present and then I'll give an overview of primary aldosteronism and what is its significance actually. So here the first case was a 40 years old male, was a known case of hypertension since 2 years. That means he was diagnosed to have an hypertension at the age of 38. And initially he was started on telmisartan 40 milligrams. His RFT, thyroid profiles was normal and he underwent a renal artery Doppler 2 years back and it was normal. That means there was no evidence of renal artery stenosis. After few months, during the subsequent follow-ups, the blood pressure was not under control and sequentially amlodipine and chlorthalidone 6.25 was added. In spite of these three drugs, telmisartan, amlodipine and chlorthalidone, the blood pressures were persistently high and he was referred for further evaluation and management. If you're going to look at him, his pulse rate was around 76. Look at the blood pressures, no much difference between the right upper limb and the left upper limb, and obviously slightly higher blood pressures in the lower limbs. Obviously it's a normal phenomenon. And again his BMI was 22.9, systemic examination was unremarkable, fundus examination showed grade 2 hypertensive retinopathy, ECG was essentially normal, and echo showed mild concentric LVH with normal LV systolic function, no evidence of LV diastolic dysfunction. And his RFT, serum creatinine was 1.3, sodium was normal, but potassium was 3.2. So just before starting chlorthalidone, the previous RFT which the patient came was totally normal. So now the potassium was 3.2, urine routine showed albumin traces. Now, as the first speaker said, is it really a resistant hypertension? Yeah, you need to evaluate. And we did an ABPM for this patient. Look at the day blood pressures. It was 160 by 106, night 140 by 92. Overall BP was 156 by 100. And look at his dipping status. He was a non-dipper. The systolic blood pressure load was less than 7.2% of that of the night systolic blood pressure load. So obviously this patient fits into the criteria of a true resistant hypertension. So now, diagnosis that was made was a resistant hypertension with an hypertension-mediated organ damage of retinopathy and left ventricular hypertrophy and hypokalemia. At this particular point of time, probably it could be due to chlorthalidone. So now, what is the plan? Yeah, this patient is on 3 drugs, optimal doses, true resistant hypertension with evidence of a target organ damage of retinopathy as well as traces of albumin in the urine and LVH on an echocardiography. So in view of all these things, though he had an hypokalemia, could be due to chlorthalidone because it was quite a very small dose of chlorthalidone. He was taking actually 6.25 and there was a significant hypokalemia. So the initial plan was to rule out an adrenal cause of hypertension, especially hyperaldosteronism. Because initially during our student days, the teaching was whenever you're going to encounter a patient who has got an diagnosed with an hypertension and has got an hypokalemia. So probably the sine qua non was to look at the primary hyperaldosteronism. But of late it has been well shown that the prevalence of hypokalemia in hyperaldosteronism is to the tune of around 10 to 37% or 10 to 40%. So that means just not looking at potassium, we should not do a workup for primary hyperaldosteronism. So now, the first thing that whenever you're going to suspect an primary hyperaldosteronism, the thing that you need to look at is the case detection. So what do we look at in the case detection here? You're going to identify a proper patient, true resistant hypertension, and your clinical suspicion, the index of suspicion should be very high for primary hyperaldosteronism. That's a case detection. So then you're going to take the help of the screening test, the aldosterone-renin ratio, and that's where the evaluation for primary hyperaldosteronism begins. So what is very important is when you're going to subject a patient for ARR, that is aldosterone-renin ratio. So here the renin action can be assessed either in the form of a plasma renin activity or nowadays the LALPATH lab and other labs are directly estimating the renin in the plasma. So aldosterone direct renin ratio is much cheaper. You can easily get it for 5 to 6,000 rupees, and if your index of suspicion is very high, there could be a good screening test to begin with for primary hyperaldosteronism. So what is very important is you need to create an ideal situation scenario before you subject the patient to ARR. What is very important is you need to take care of certain drugs which is going to be responsible for either the ARR to be either false positive or false negative. So very important is either the potassium wasting diuretic. So especially the CTD. In this particular patient, the CTD was stopped, hypokalemia was corrected. You should always advocate a liberal salt intake. Either a low salt intake or a high salt intake will have an impact on renin and aldosterone. Amlodipine was stopped here because it's going to cause a reflex increase in the renin levels. And telmisartan, though there is an school of thought which is totally different, either you have to stop an ARB before an ARR, or you can continue during the test of ARR. So in this particular patient, because the blood pressure was quite high, and it's a class 2A recommendation whether you want to stop an ARB before an ARR or not. So I kept it, I did not change it. I changed amlodipine to verapamil. I added prazosin. So I waited for 2 weeks, and after 2 weeks, an ARR was done. So look at here, the plasma renin levels were 1.05 milli international units per liter, where the normal range is around 4.4 to 46, and the plasma aldosterone levels were 42.6. So whenever the plasma aldosterone levels are more than 20 nanogram per deciliter, almost it clinches the diagnosis of hyperaldosteronism, but obviously if you want to say primary, the renin level should be very low. So here the ARR was 40.6. So normally the ARR is less than 20, and above 20 it is elevated, and above 40 it is significantly elevated. So probably the first criteria of case detection, yes, we are pointing towards primary hyperaldosteronism in this case. So now the confirmatory test. So what is very important is before you embark on the subtype analysis, what you're going to look at, whether it is due to an adenoma or an hyperplasia or so on imaging, you need to do a confirmatory test. So what are the options that we have here? Saline infusion test, captopril challenge test, oral sodium loading test, and fludrocortisone suppression test. But in my case, because the patient had a significant hypokalemia just with a very small dose of diuretic, resistant hypertension, and the ARR was significantly elevated, I skipped the confirmatory test here, and I just moved on to the imaging of adrenals. So we're going to look at here across. Normally the adrenals are very difficult to pick up. They're too small on a CT. But if you're going to look at here, so if you're going to look at here, the adrenals are very, very obvious. So either they're going to be present in the form of a V shape or a Y shape or a very prominent limbs actually, wherein their attenuation levels either in a plane or a contrast imaging will be almost similar to that of the rest of the adrenal gland as well as to the muscle, wherein the Hounsfield units will be around to the tune of around 10 to 40. So this was very, very obvious, and the diagnosis of an bilateral adrenal hyperplasia was done. So now we have fairly come to a conclusion that he has a resistant hypertension, he has a primary hyperaldosteronism secondary to bilateral adrenal hyperplasia. So now very important is, now we need to look at, we know that this particular bilateral adrenal hyperplasia is a functioning adrenal hyperplasia. Most of the times it will be due to a cortical hyperplasia. So we need to look at whether there is any subclinical Cushing's or excessive production of cortisol. So I did an 1 mg dexamethasone overnight suppression test, wherein the patient was given 1 milligram of dexamethasone in the night, and we did his 8 a.m. cortisol in the morning. The 8 a.m. cortisol was 1.2 microgram per deciliter, wherein the value is less than 5. So that means there is no evidence of hypercortisolism in this patient. So now coming to the management, it's very clear. We know that we are dealing with secondary hypertension. It is bilateral adrenal hyperplasia, hyperaldosteronism. Obviously, it's a Conn syndrome. So now coming to the management proper, because it's a bilateral adrenal hyperplasia, the option that we have is not surgical, it is only medical management. So we have got wonderful drugs, the MRAs, the mineralocorticoid receptor antagonists, The first drug of choice is spironolactone. In case if the patient is intolerant to spironolactone, the second option is eplerenone. So this is how I manage this patient actually. The patient was on spironolactone, which we had changed to verapamil instead of amlodipine. I switched back to amlodipine and telmisartan was continued. So that means the patient was on telmisartan, amlodipine and spironolactone, and the blood pressure at the time of diagnosis was 156/102. In the follow-up, after 1 month, the potassium came to 5, so I removed telmisartan. I continued amlodipine and spironolactone, and after 1 month, the blood pressure was 130/80. I stopped amlodipine and put the patient only on spironolactone. So that means, so once you have achieved or targeted the diagnosis and you have done a proper diagnosis and treat it appropriately, look at this now, we have moved from a resistant hypertension to a simple hypertension which has got a wonderful treatment, and our blood pressure is come under very good control just with 50 milligrams of spironolactone. So what is very important is you need to have a high index of suspicion. So I'll just move on to the second case. So this is a 45-year-old female, known case of hypertension, diabetes, hypothyroidism, presented with dyspnea on exertion class 2. And she also had snoring, daytime sleepiness, and she was referred in view of uncontrolled blood pressure. The blood pressure was 155/100 millimeters of mercury. BMI was 30.5. Systemic examination was unremarkable. Look at here the number of medications she was on. Amlodipine 10 milligrams, hydrochlorothiazide 12.5, olmesartan 20, and prazosin 5. So these were the set of medications the patient was on while she was referred for the evaluation. TSH was normal on replacement therapy. Creatinine was fine. Electrolytes were pretty good. Renal artery Doppler was normal, no evidence of renal artery stenosis. Urine albumin traces. Fundus showed grade 1 hypertensive retinopathy. ECG showed LVH with strain. Echo showed concentric LVH, no RWMA, with an RV systolic pressure of 55 millimeters of mercury. Very evident, moderate pulmonary hypertension, not due to LV diastolic dysfunction, because her LV diastolic functions were normal. And again, we need to reconfirm whether it is a pseudo-resistant hypertension or a true resistant hypertension. Look at the ABPM values again, totally out of range, and she was a non-DIPA. So now the diagnosis again, very clear cut. Resistant hypertension, diabetes, hypothyroidism, obesity, moderate pulmonary arterial hypertension with the classical history of snoring, daytime sleepiness, obesity, so on. I had a high index of suspicion of OSA in this particular patient. So what did I do? I sent this patient to the pulmonologist for a sleep study. So what was the outcomes of this sleep study? The patient had an AHI of 39.1, apnea, hypopnea episodes per hour were around 40, which clear-cutly fits into a severe obstructive sleep apnea with a significant desaturation of around 88% during the snoring times. So yes, I was very happy that my suspicion was OSA, and this turned out to be OSA in the sleep study. So our pulmonologist put the patient on BiPAP, 14 bar 4 centimeters of water after auto CPAP titration, and after 1 month the patient felt better, breathlessness improved, and the blood pressure came down to 146/94. That means there was significant improvement just with BiPAP, along with the regular medications the patient was taking. And she was advised a review after 1 month. So meanwhile, this particular patient had an abdominal pain, went to a surgeon, and CT abdomen was advised. So when I had not suspected any adrenal pathology in this patient, my suspicion was OSA, and I evaluated for OSA, and OSA was treated. But still the blood pressures were not under control. So when a CT abdomen was done for some other reason, and the radiologist picked up an incidentaloma, that is a right adrenal adenoma. So now the question came, if you're going to look at across a very significant, very clear-cut, well-defined, homogeneous tumor or an adenoma which is arising from the right adrenal gland, look at across the HU units of around 5.44. And again, if you're going to look at across the contrast film again, the relative percentage washout was 50%. So almost saying that this right adrenal mass was an adenoma, non-malignant and benign one. So now the question came across whether this is a functioning adenoma or a non-functioning adenoma, probably could be an incidentaloma. So now we started reworking actually. What we did here again, took off the medications which are going to come in the way of ARR. We did an ARR and the aldosterone-directonin ratio was 40.5, significantly elevated. 24 hours urinary fractionated metanephrines was done just to rule out pheochromocytoma. It was negative. We did again a low-dose dexamethasone suppression test. It was normal. So that means it is a functioning adenoma. So probably it was an overlap with an OSA as well as an primary hyperaldosteronism. So now what I did here, now because we know that it is an adenoma, it is functioning. Now there's a clear-cut treatment for this wherein you can subject the patient to unilateral adrenalectomy. So before subjecting a patient to a major surgery, I need to confirm it actually. So what I did here, after all the options that I had for a confirmatory test, I chose a saline infusion test when the patient was given 2 liters of normal saline over a period of 4 hours, and after 4 hours, we checked the serum aldosterone levels, and that was 25.6. Normally, when you're going to use an saline as a challenge, and if you're going to infuse, the aldosterone level should fall. If it is persistently above 15 nanogram per deciliter, it is almost confirmed that we are dealing with an hyperaldosteronism state. So, it's very clear cut now. We have detected the case now. Now we have done a confirmatory test, and the patient was started on spironolactone 50 milligrams, and the patient attenders were counseled about the need for laparoscopic unilateral adrenalectomy. So now, look at here. The patient was on therapeutic lifestyle change, and the initial drugs were olmesartan, amlodipine, hydrochlorothiazide, and moxonidine, and the blood pressures were 150 by 100. When we added the BiPAP to the patient after the diagnosis of OSA, the number of medications remained the same, but the blood pressure came to 146 by 94. Once we introduced MRA, with the reduced doses of medication, the blood pressure came to 130 by 84, and the patient underwent laparoscopic unilateral adrenalectomy by our urologist. And look at the response to the treatment. Just with minimal 2 drugs, the blood pressure came down to 134 by 80. So this is the beauty of diagnosing a secondary hypertension, because we know that we can treat it. So just 2 slides to talk about the primary aldosteronism. It's also known as Conn's syndrome. Conn's based on the name given to it based upon the guy who has, who presented to us. And primary hyperaldosteronism is a group of disorder characterized by inappropriately high production of aldosterone. It is commonly caused either by an adrenal adenoma or a unilateral or a bilateral adrenal hyperplasia. This causes inappropriate aldosterone secretion, which in turn causes suppression of plasma renin, sodium retention, hypertension, hypokalemia, and cardiovascular damage. So cross-sectional studies and prospective studies have shown a prevalence of PA to be in the range of 5 to 10% in the various settings. And normokalemic hypertension is quite common. So normally we expect an hypokalemia to be there, but normokalemia is quite common in patients with hyperaldosteronism, and only 9 to 37% of the patients with PA have hypokalemia. This algorithm, very important: high index of suspicion, case detection, aldorenin ratio, case confirmation, medical treatment versus surgery. So now, why is primary aldosterone important? The reason being prevalence, quite prevalent. Patients with primary aldosteronism have very high cardiovascular morbidity and mortality. Why? Because when you're going to take age and sex matched controls who has got hypertension due to non-PA etiology versus a PA etiology, they have got a worst outcomes. That's going to talk about the bad effects of aldosteronism on the cardiovascular health. And now we know that we have a specific treatment for that, MRAs or unilateral adrenalectomy, and treatment is going to resolve all the ill effects or adverse effects of hyperkalemia And that is the beauty of diagnosing a secondary cause of resistant hypertension and treating it adequately. So thank you for your patient listening.